first welcome formally Mr. Graham Binning from Fire and Rescue, our new member, and we have also accepted membership from Northumbria Police, and there is no one here in this meeting, but I also welcome them on board. First item, apologies for absence.
Apologies from Paula Mead, Rachel Mitchison, Graham Writer, Councillor Renner Thompson, and Simpson, and Claire Wheatley from the police.
Claire Wheatley, okay. That's the Northumbria Police, isn't it? Thank you very much, Leslie. So, minutes of the previous meeting held on 8th September. Can I record them as a true version of what happened? Thank you. Disclosures of interest. Anything else? Thank you. So that brings us to item number 4, Northumberland Healthy Weight Declaration. And our executive, Liz Morgan, will be leading that one. Thank you.
Thank you very much. So hopefully this paper is sort of reasonably self-explanatory. The Healthy Weight Declaration is something that we would like to progress along with North Tyneside and Northumbria Healthcare Trust. It's a really good way of raising awareness and supporting leadership around healthy weight, and we know that obesity and unhealthy weight are becoming increasing issues across our county, particularly in children. So the purpose of the paper really is to get the board's support to support this healthy weight declaration, and that will really act as a sort of launch pad for a whole range of other activity that we're intending to do over the next few years across the whole of the system to support our healthy weight activity. Before the pandemic, we were doing quite a bit of work to support a whole system approach to healthy weight, and unfortunately that had to be put on the back burner because of the COVID. So it's a really good opportunity to pick that up and make an impact on something which is a real issue for residents across our county.
Any questions to Liz Morgan based on the report, Healthy Weight? Okay, I think we are being, sorry.
Just to say, excellent report and absolutely important. I think during COVID, a lot of us put weight on. So I think it's really important we look at this.
Thank you, Wendy. Thank you very much. Is there any other compliments? Yes, please.
I wasn't going to say anything.
Because we have been asked to adopt this report, so any more the better. Thank you.
Yes.
Thank you. Again, it's a very commendable report and well timed. But might there be a little bit more emphasis on what schools can do? Because you have a list of recommendations and so on. So to what extent is the education department directly involved in this? Because childhood obesity is very, very significant, as well as adult obesity.
Yeah, I mean, I think that the childhood obesity issue is, it's something we really need to focus our activity on, because we know that overweight children tend to become overweight adults. And as part of this sort of whole system approach, there will definitely be a focus on children as part of our sort of wider Best Start in Life approach. I completely agree with you. It's really important that we focus on children, young people and their families, and that we sort of have those conversations at the earliest possible stage, usually actually before children go to school. And I think we will be engaging with education to see what can be done in the school context, definitely.
I just asked you about 16 specific. Oh, it's still on. You have 16, very worthwhile commitments. I just didn't see a specific one on education and on schools, which we agree I think is particularly important.
I think that would probably come under number one. So the sort of system-wide approach to obesity. I think education would definitely fit in there as part of that equation. But I take your point, and we'll make sure that that is explicit in any plan that we come up with.
Thank you.
Any further questions? Yeah. Yes, please, Graham.
I think probably the relative quietness in the room is because it's just so easy to agree to this. But I do think probably with all of the stresses that are going on in communities at the minute to do with COVID and poverty, it's something that hasn't been top of our agenda for a while, and it's probably a good time to refocus. And I think all of our organisations all know that this is a really significant issue. We'll hear about perhaps some projects in primary care and population health management later, but I think that's probably why we're all just nodding, because yes, of course we would. Yeah.
Yeah, and I think it's interesting point about cost of living, because actually it's very much linked into the cost of living issue. I mean, even before we saw this sort of increasing financial pressure, some families were spending, could potentially spend 75% of their disposable budget trying to provide a sort of healthy plate in accordance with the government recommendations for their families. And, for a lot of families, that's just not sustainable. So, it's going to become an increasing issue.
Thank you, Liz. Any other comments? Okay. Okay, then we will move on to the next item. Number 5, Northumberland Joint JSNA by Pam Lee. Thank you, Pam.
What we're going to try and do this morning is use the newly developed JSNA website to walk our way through this paper. So I'm hoping that we're going to be able to display this on the screen. This is absolutely brand new. It actually hasn't gone quite live yet. I'm hoping it goes live sometime today. And so what we're going to do is talk about the JSNA and hopefully be able to see some of this and interact with it. But you're going to have to bear with us, okay? Is that all right? So you've got the paper in front of you. And really what we want to do this morning is kind of 3 things, I suppose. One is to strengthen the process and the governance around the JSNA. Over the past few months, members have seen quite a number of needs assessments and chapters of the JSNA that have come here, but what we've been lacking, I suppose, is a bit of structure around that. So the proposal is to establish a steering group which will help us to refresh the joint health and wellbeing strategy and take that forward as we move through all of the other things that you've been talking about recently, the inequalities plan and the cost of living crisis. So all of these things actually come together, and it's really important that as a board we recognise that and we realise that we're moving all of these things at the same pace. So what we want to do is establish the steering group, and we need your permission to do that. And the idea of the steering group is that that will determine the priorities for the JSNA, so determine which areas we're going to work on in what order, and also to take ownership of the recommendations and the actions that come from that, so that we come back to the Health and Wellbeing Board if we need to escalate something. So that it kind of takes away that operational bit from the Health and Wellbeing Board and puts it more into a steering group, which will be officers. So that's one of the recommendations. The other thing is that within the framework that we use for the Joint Strategic Needs Assessment, we talk about what assets we have, but we don't actually make that explicit in the title. So what we want to do is change the title from being the Joint Strategic Needs Assessment to being the Joint Strategic Needs and Assets Assessment. And I think that just kind of, like I say, makes it more public, and it just makes it clearer about what we're actually doing and how we're approaching this. So that's the first thing we wanted to do this morning. The second thing we wanted to do is just talk you through some of the progress that has been made. And I don't want to go into a great deal of detail about this, but what I'm hoping we'll be able to do is show you some of this. So one of the things that's in your papers is the recommendations from the Veterans Needs Assessment that we had done. So if somebody was interested in that, for whatever reason, whether it was somebody from the voluntary sector or if it was somebody who was actually a veteran and they wanted to know what we were doing in Northumberland about it, if they click onto communities of interest, and this is where you have to cross your fingers and hope this is going to work, and there you go, you can see it comes up. So this takes us into the armed forces and veterans. And then if we click into that again, it will give us the full report so that people can, so it's quite intuitive. And the other thing about this is by working it as a web-based resource, it means that the data is constantly updated. So if somebody has written a topic for the JSNA, they don't have to go back every 6 months or every year when new evidence comes to light or when the data is updated. This will do it automatically for us. So that's that's one example. People who were here last month will remember that we accepted the pharmaceutical needs assessment. So the pharmaceutical needs assessment is also linked to this. And if we go back to the home page, where we have key strategies and other documents, things will go in there like the Health Inequalities Plan that was also agreed at the board last month. And you will see that census data is on there, and also there's a feedback section. So people can give us their feedback in terms of whether they think this is useful, whether they think we're missing something, or whether they think this is actually not a particularly useful way to present it. So we can have feedback. So I would, when the link goes live, we'll make sure that you all get a copy of that link and you will be able to go on and kind of test it and see what's on there and see what you think's missing. So all we need from you is to approve those recommendations, and I'm happy to take any questions.
Thank you very much, Pam. Are there any questions for Pam?
Hi,
Wendy.
Hello. Thank you so much, Pam. That's great. And obviously, I think the recommendations are great and very, very happy we take this forward. I like the Army and Veterans thing as well. I know that there are issues in Ashington. We do have, I think, quite a few homeless veterans, etc. I'm really keen that we do promote this. So thank you very much indeed. Thank you.
And that's a really important point about how we bring those data sets together. So how we look at the veterans data set and how we look at the homeless data set as well, to make sure that we're putting our efforts into the right places.
Absolutely. No, fully approve.
Yes.
Thank you. Just to say, I think it's fabulous. We are constantly looking for information like this. I know hounding yourselves for this kind of information from an external partner. And as part of community transformation, we've been looking at the data. I've been sharing what I get here to influence that, but this is great. So thank you.
Yes, please, Graham.
Yeah, as my first attendance at my first board, I'm delighted to be here, and it's just to say that it's really encouraging to see that fire and rescue are now in a line of sight for this joint strategic needs assessment. This is absolutely the progression route that the Fire and Rescue Service, with regards to our collective, as part of the collective contribution, this is exactly where we want to sit and need to sit. So just endorse it even more. Thank you.
And does that mean you'll join the steering group?
We will have somebody on that steering group, yes.
Great, that's great, thank you.
Thank you very much. I think there was one concern we had, isn't it? It's at page 39. There are some references to CCG, which needs to be removed, I think, Pam. So
yes,
that's
thank
one.
You for that. It was probably written before then, so yes, yeah. Thank you.
Okay, thank you. Are there any other questions? Thank you very much for all the compliments, and let's move on to, thank you very much, Pam. Thank you. So let's move on to the number 6, item number 6, which is population health management update. I think there's going to be a presentation.
Thank you, Chair. So yes, I'm Alan Bell. I'm Senior Head of Commissioning for Northumberland Place Integrated Care Board, and I've got my colleague David Cummins, who's the GB Clinical Lead for the ICB2. I'm just going to introduce the slides and just give you a brief understanding of what we're going to talk about today. So the update we're going to give is on the back of an update Robin Hudson gave to the board, I believe, back in May of this year, and really understanding around population health management and how that's taken forwards and is looking to address the inequalities agenda across Northumberland. And where in that previous update, children and young people was a significant focus of the update, and some of the projects we'll talk about today just highlight some of the work that the primary care networks across Northumberland are looking at. Also, I'm aware that the voluntary community sector and that inequalities work that's going on there is something that's very important, and certainly the primary care network projects that we've are supporting at the moment as an integrated care board very much link in with the Health Inequality Summit and the Inequalities Plan, which I believe Jill O'Neill and Public Health team have developed. In terms of the support for the primary care networks, each of the primary care networks, which are seven of across Northumberland, have been given resource to focus on population health management projects and look at areas which really they want to address inequalities within their particular areas, and that's covering maybe the 3 I's, so looking at infrastructure and looking at getting the right people around the table to address and talk about the issues that they've found, looking at getting the right intelligence. So some of that and the resource we've given is to make sure we've got public health, business intelligence from a secondary and primary care side of things, and then ultimately looking to use that intelligence to form local interventions. Colleague, I'll let David introduce himself, but he's been focused on working with those 7 primary care networks and supporting them to understand how they can identify the resource, and then looking at working through those projects in each of the 7 primary care networks. So I'll hand over to you, David. Press down to go next. To press the button.
Good morning, everyone. As Alan mentioned, I'm David Cummins. I'm a GP working in Linsonville in Ashington, which is part of the Valence Primary Care Network. I also work as clinical lead in population health management for the ICB. So the map of Northumberland here just shows the 7 primary care networks that Alan alluded to. So on the right-hand side, you've got some of the more urban primary care networks, such as Valence, Wansbeck, Blythe, and then you've got the more rural ones like Well Up North and West, and then a combination of the 2, which is Northumbria Primary Care Network, which is our newest one. You'll notice the colour codes there that vary between green and red, and we'll go on to this in the next slide, but essentially red means more deprived and green means more affluent. So from a health inequalities perspective, if we zone in on the southeast corner of the county, I like to introduce this slide at the beginning of some of my talks, because we can see here that within the southeast corner of Northumberland, there's quite a significant difference in terms of levels of inequalities, levels of income, and levels of deprivation. So looking at 2 different areas in the primary care network in which I work, if you focus on an area in Morpeth, the average household income after tax is £44,000. But if you drive 5 miles down the road to Ashington, that same family after tax has an income of £26,500. So you're looking at an almost 70% difference in disposable income. And you can imagine the significance of that in day-to-day life. So this is a slide that was developed by the public health team, and it's a mythical bus journey through Northumberland, and it talks about life expectancy. And if you look at the 2 circled areas, you can see the difference in life expectancy for men and women comparing Ponteland to the Hurst area of Ashington. And for women, there's a 17-year gap, and for men, there's a 15-year gap. So as Alan mentioned, the primary care networks are looking at population health management projects, and these are detailed in this slide, which you won't be able to read, but I fill this in and update it every week. The networks have all focused on individual projects that they feel are specific to their needs. So at the beginning of this exercise, they had dealings with the public health consultants from the local authority. They were given data packs, data profiles, and they were sort of guided and advised as to what their area of focus might be. And I'll go into each PCN in the coming slides. So as you can see in the third column there, each PCN, or most of them, have an assigned public health consultant. And I know Pam Lee, who's just spoken, she is the public health consultant for Well Up North. So going through each of the 7, so Cramlington and Seaton Valley PCN, they've decided to focus on patients who are aged between 35 and 65, who are living in the IMD1, so the most deprived decile. They're looking at patients who have a coded diagnosis of depression, as well as a diagnosis of either cardiovascular disease and COPD. And what they've been able to do is link their primary care data with a deprivation data set and come up with a cohort of about 100 patients or 150 patients who have now all received a letter of invitation asking if they want to be part of this project. And the intervention as such will be led by the social prescribing link workers, and it's going to focus on things like a well-being score, alcohol intake, BMI, smoking, and they'll be looking at their well-being scores before and after, and they'll be trying to see what outcomes, what interventions, what sort of progress can be made with those cohorts with respect to their diagnoses of depression, COPD and CVD. Valence PCN, where I work, we've decided to focus on high-intensity users or frequent flyers. And looking at our data, we found 433 patients who have had 10 or more GP appointments in the preceding 12 months. And we've been linking in with NEXT, which is Northeast Clinical Support, and we're trying to get them to help us to refine and cleanse our data so that we can then link them up with 999 and 111 data. So find out what patients from our group are also the highest users of 999 and 111 calls. And the plan is to identify 30 to 50 high-intensity users and again create a bespoke intervention that's based on the social prescribing link worker that might then be able to link them in with the likes of physios, pharmacies, nurses, GPs, mental health practitioners. These are part of the additional roles that practices have funding for. So perhaps one of the most interesting projects is being done by OneSpec PCN, and their main branch is in Ashington, and they've decided to focus on child poverty. So I just thought I'd mention that when I moved to the Northeast 7 years ago, child poverty was lower here than the England average. But now for children in households with an under 5 in the Northeast, almost half of them are in poverty. And actually 75% of children living in poverty are from working families. So these data are for across the PCN, so the average is 26% for OneSpec PCN, and that's greater than the England average of 17%. So these are the sorts of data that we can see that we get from the public health teams. We can find these hotspots, these postcodes where child poverty is more prevalent, and we can see there that the Hearst area of Ashington and Ashington Central have the highest levels. And this slide talks about crude numbers, so we can see here that the Hearst area of Ashington has 507 children living in child poverty. So this gives the PCN an idea of where they might focus their efforts. So what they've decided to do is to focus on 15 children from the Bedlington East and Hearst wards. And their intervention is taking this multidisciplinary approach. So they've had involvement from Cygnus Support, which is a local charity that deals with mental health, local regeneration groups, citizens advice, safeguarding teams, community link workers, and the Ashington Children's Centre. And we had a really useful brainstorming session last week where all of these stakeholders came around the table and we discussed the way forward. So again, a lot of these interventions, as you'll see, they seem to focus on this social prescribing link worker approach, So wider MDT is coming together to try to improve the lives of these 15 patients who will be identified. So the intervention will be like a mixture of mentoring and involving other support from the wider community. So in terms of searching for these patients, I won't go into detail on this here, but there's lots of different ways that you can actually try to identify these patients. You can look at things like A&E attendances. You can look at how many children are in the household, whether there's an adult in the household who's a current smoker, obesity prevalence in year 6, things like that. So well up north, I know Liz Morgan mentioned childhood obesity, and this has been one of the focuses of Well Up North's project work. So they've decided to look at the National Child Measurement data, and they've decided to target parents of children who are in the top 20% of weight. And they've had various meetings, various workshops with stakeholders, including Sure Start, the local authority public health teams, Henry Plus, which is a program that helps children who are overweight and obese. And they're hoping to use the children's centres in the county that are now due to become family hubs. So they're looking to receive referrals from health visitors, school nurses, self-referrals, as well as referrals from GPs to hopefully make some inroads in tackling childhood obesity in the PCN. We're fully aware that it's unlikely that we're going to make a dent in this very difficult area, but I think it's definitely worth trying. I should mention that this is common for all PCNs. One of the barriers that's been encountered has been the issue around data. A lot of projects have been a bit difficult to progress because of data sharing, access to the correct data, and data analysis as well. So Northumbria PCN is the newest. That's only been in existence for the past few months, and they've decided to look at smoking in certain cohorts, but also they're looking at variability in cancer screening uptake across their PCNs. And as I mentioned earlier, they've got quite a wide geography going from rural to urban. They're looking to improve the smoking training that they have available to staff. So MEC training is now something that's being rolled out to all of their staff. And as I said, they're hoping to choose a vulnerable cohort of smokers to target with their project. The West PCN are looking to do a project on alcohol identification and brief advice. So they have identified a cohort of patients who have a BMI over 30, as well as a coded diagnosis of anxiety, and they are looking to provide these patients with alcohol brief advice, and they're looking to target between 30 and 60 patients. And again, their intervention would be looking to include the mental health practitioner, be considering input from the Northumberland Recovery Project, and doing things like blood tests and ultrasounds on patients that might potentially have been missed. So Blind PCN, they're doing quite an interesting project on A&E attendances in the 0 to 4 age group. So we decided to focus on attendances as opposed to admissions, because their data that we got from NEX was showing a significant increase compared to the rest of the county in children in the 0 to 4 age group who were attending A&E, but also attending urgent care. And in the slides that follow, we can see how these are broken down, but essentially the highest rates are from the wards Coupon and Kitty Brewster. We had a really useful meeting a few weeks ago that was attended by people from Health Watch, from Early Health, from Public Health, from health visitors in the 0 to 19 group. And the intervention there, again, it's going to be multidisciplinary. We're hoping to have engagement work with families to try to find out why it is that they are choosing to take their children to A&E as opposed to potentially going to the GP. They have enlisted Health Watch to do surveys with parents to capture why this might be the case. And in terms of other groups that are coming on board, so we're hoping to get input from one of the local paediatricians in NSEC. Interestingly, they also have a secondary focus, which is on childhood obesity, and they've had a recent healthy weight workshop that also took place. So I should mention that some PCNs are doing not one but two, in some cases 4 projects. So sticking with Blythe, the asterisks there, they will show that A&E attendance in the 0 to 4 cohort was significantly higher than the England average. And these are data that we received from NEXT that show quite an easy breakdown in terms of practices. You can look at the months, the year, the age cohort, and how it travels throughout the year. The most popular day for attending A&E and urgent care is usually a Sunday. The most popular time is 6 p.m. And there you have the wards, as mentioned, Kitty, Brewster and Coupon, which are the highest users of A&E. In terms of why these patients attend A&E, most of the time it's because of viral illnesses and injuries. But interestingly, a lot of the investigations performed are minimal. So most patients don't get any investigations. It's simply observation. So one of the questions is, certainly from a financing point of view, is could these patients be better managed in primary care? This is just a quick slide on prevalence of overweight and obesity, because that, as I said, was one of their secondary focuses, and this is a hotspot area. It shows us what wards within the Blythe PCN are the highest in terms of reception obesity prevalence. So across the 7 PCNs, there have been common themes over the past 12 months, and as I mentioned, one of them is data sharing. That is it's a major issue, and we're trying to get data sharing agreements in place so that data can be accessed more easily and we don't have to spend quite a lot of time getting this together. So certainly access to data, analysis of data has become problematic. I will mention that some of those projects are quite complex, certainly childhood obesity, childhood poverty, and as I mentioned, we're not under any illusion that we are actually going to tackle these properly, but I think starting is always a good thing. But one of the real positives from the past 6 to 9 months has been the engagement, and I think everyone's been blown away by just how much is actually happening out there in Northumberland. And GPs who are now doing this work are just fascinated by how they can link in with the community groups that are local to them that they otherwise would not have heard of. I'll just finally mention, as Alan alluded to, that we're very aware of Jill O'Neill's Health Inequalities plan, and I think a lot of these bits of work that the PCNs are doing, they nicely complement this wider plan. So thank you, and happy to answer any questions.
Thank you very much, both of you. Thank you very much. It was a very comprehensive report. Focusing on different areas, what you are doing, so that will be very useful for our inequality theme, pursuit of inequality theme and everything. Now, are there questions from the floor, if I can? Wendy?
Thank you very much, Chair. Every report which comes to the Health and Wellbeing Board is important and always interesting. But I have to say, I've really appreciated this report that you've done just now, especially regarding child poverty. I think you're all to be congratulated that we're really looking hard at child poverty in Northumberland. I just found this really interesting, and I wondered how often could you come back and tell us how this is progressing, your work and your insights. I'm incredibly grateful for this report.
I'm more than happy to come back anytime.
I'd love to see you as often as possible, if that's all right, Chair. Yeah.
Sure.
I just want to congratulate you all. Thank you so much, everyone. It's really important to our residents that we don't have any child poverty. That's the aim.
Thank you. Yes, please.
Thank you. Just echo what Councillor Patterson has said there, because this is an excellent report, because it's a local area, a local primary care network using local evidence to come up with local priorities. And we can see in different parts of the county the priorities are different. So I think that's excellent. Just one question, if I may. You mentioned engagement. Do you engage with the PPGs, the patient participation groups, so representatives of the local community they are aware of what is happening, they're engaged with it, and can perhaps help you in your very positive outcomes?
I think that's a very good question. I think certainly all PCNs do engage with their own PPGs. I can probably tell you a little bit about Valence PCN where I work.
Yeah.
Our clinical director, interestingly, and this is something that came out of the Health Inequalities Summit in March, he's quite interested in changing the focus of the PPG so that it becomes more focused on health inequalities, and he's thinking about making that a health inequalities group, I think. But I myself haven't had any personal dealings with the PPGs, but I agree involving patients in these steps is very important.
You have any follow-up questions?
Well, not a follow-up question in a way, but engagement is critical in all of this, beyond the detailed evidence you've secured from, local analysis and so on. But I would have thought if there could be a move to encourage each PCN to actively engage with, their patient participation groups, not just some of them, but all of them, I think that would give some reassurance to people who are perhaps influential in their communities.
I'll take that back to the clinical directors when I next meet them. Thank you.
Thank you.
Thank you. Thank you very much. Excellent work. Come an awful long way. Population health management is a confusing field, and when you start to see practical applications of it like this, it really helps to realise what's going on. Semantics, we have an inequalities plan, which covers all inequalities, so we try and not to use health inequalities plan in that sense. However, I think I can see what's happening here is a pincer movement. So on the one hand, we've got a health focus on data and health inequalities. On another hand, we've got work going on around asset-based community development, which is very much about avoiding what we're calling interventions and actually building up around inequalities from the base, essentially. We had a really useful session here yesterday with elected members with Cormac Russell introducing the concept of asset-based community development and exactly how we engage with the communities and how we build from the base in the communities. So I think putting those two things together, so it's absolutely essential that these dovetail and that we don't go off on tangents. And I know you're involved, so that's good. So thank you.
Okay. You have a question there.
Yeah. Hi, I'm Suzanne, and I'm Deputy Director of Nursing with Harrogate District Foundation Trust. So we've just completed a restructure and a complete remodelling of the 0-19 service in Northumberland, and I was really interested to see some of the projects because they really do align quite closely to some of the thematic leads that we're going to be developing within the 0-19 service. So in order, it really made me think, in fact, about how we can develop that further. So there's some key contacts and some key posts that we're going to be appointing to, one of which is kind of a community anchor post, which is very much about developing partnerships and making sure we have strong links with all our partners. So I think it's really important that we link up in that, so you've got a clear single point of contact within the 0-19 service so we can work together on some of these projects.
Thank you very much. Yeah, totally agree. I'm more than happy to communicate with you by email.
Any other questions? Yeah, sorry, Glenn. Go on.
Good morning. Wendy Patterson is our executive cabinet member responsible for older people and communities generally. I'm the leader of the County Council, and we did have a good meeting yesterday. My intention, by making tackling inequalities one of our 3 key priorities, along with growth, value for money, was to try and bring some clarity to my mind, because I find this subject so complex. When we talk about fuel poverty and child poverty and inequalities generally. So the idea was to say we must form an action plan, and our staff have very kindly gone away and done that. We have this action plan. We actually have some money behind it as well. But the key thing for me is that we continue to keep it simple. so that we know as a county council what we're trying to do with our key partners, and that we monitor ourselves very, very carefully and very regularly. And hopefully the Health and Wellbeing Board will be the way to do that. So when Wendy says, I hope you can come back, yes, that is actually vital, if you don't mind, that you do. And I think, you know, if we could come back to this and see, okay, what have we actually achieved in 3 months since we had that meeting, and we've had all the, you know, we've taken the action plan through Cabinet and to the Council. What have we actually achieved in this last 3 months? And that's really what I would like us to do, so that we don't all go off in different tangents. We remain focused on the key points within that action plan, so that we can make a difference. I know it won't happen straight away. Of course it won't. But, you know, I, for example, look at inequalities around social inequalities and cultural inequalities and work inequalities. And I honestly think if we can find jobs for a lot of people that would like to work that can't for all sorts of reasons, that will make a huge difference as well. And I think Northumberland Skills are doing a fantastic job there, which I visited the other week, taking kids that have had a hard start in life and teaching them skills that will make them money, that they will become, you know, moving out of the system they're in at the moment. So anyway, I just think it's a complex subject for me anyway. But if we all can join in and work together on this, I'd be really grateful and come back to this. But there has to be this level of self-examination about what we've actually done in the last 3 months, every 3 months, I think. Thank you.
Thank you, Glenn. That's a very important point. Yes, we need to be focused on action plan and everything. Thank you, that's a good point. I have a very minor question. When you say smoking is just a traditional smoking, or we also take into vaping? Because I work in city center, I work in the university, actually. I see lots of young people with vaping. Is it considered harmful? Or what is the medical opinion? Or does the smoking include vaping as well?
So I think the data that we have on smoking will be cigarette smoking or smoking rollies. I don't think that will include vaping. I think from the NHS Stop Smoking Service locally, my understanding is that vaping is considered 95% safer than cigarette smoking.
Right. Okay.
Although I think that the jury is still out in terms of long-term evidence on the safety of vaping. But
thank you very much. I just thought I would clarify myself where the vaping starts. Thank you. Thank you very much. Yes. Are there any? Please, Liz.
Really good presentation. Thank you, David. And I think it gave a really good flavour of actually what impact these projects are having on the ground and what you're trying to achieve through this population health management approach, which I think a lot of people sort of find really complex. Just picking up on a couple of things. The work that you're doing around child poverty, we're doing something sort of very similar in the council as part of our poverty and hardship plan. So really collecting all of the relevant data that we've got, triangulating that data to look for communities where the uptake of benefits is low, and then providing some targeted support for those communities, sort of pop-up events which are being done by Northumberland communities together, so that we can support people into the benefits system, because we know that there are, you know, tens of thousands of people across the county who aren't claiming the benefits that they're entitled to. So what we're hoping to do actually is to do that down to individual household level, which some other local authorities are doing. So I think that work sort of links in quite largely to the bigger picture. The childhood obesity work, I mean, that's sort of really complex, isn't it? And I feel as though we're trying to, you know, empty the ocean with a teaspoon. There's a real sort of paucity of evidence around what works to manage healthy weight in children, so particularly in the long term. So it would be really useful if there was sort of an evaluation element included in that bit of work, just to see whether what you're doing works or not. If it doesn't work, actually that's as useful as if it does work, because then we know we focus our activity on something else. And then the last thing was really around data sharing, because that was one of the basic things that came up as part of the first summit that we had was this issue around data sharing, and we do really need to crack on and look at what we need to put in place to share data across the system, because we could do so much more if we could do that effectively. And that is a central theme in the inequalities plan, so hopefully we can get better at doing that over the next few months. But thank you very much, David. It was a really good presentation.
Just briefly say something about the first 2 points, and then Alan might want to mention something about the data. From a benefit point of view, I'm really glad you made that point, because I'm aware that in Northumberland, I think in 2019-2020, almost £40 million worth of benefits went unclaimed. So Jim Brown, one of the public health consultants from the council, Orla Collins, who's the clinical director for Wansbeck, who's doing the Child Poverty Project, the two of them and I, we've met, and we're looking at trying to get benefit advisors into practices so that they can help patients retrieve benefits to which they are entitled. Your second point around childhood obesity, and I suppose the other projects as well, there definitely is a plan to have an evaluation towards the end, so we will come back to you with that. And Alan might want to mention something about the data side of things.
Yeah, thanks, David. So yeah, certainly, I guess as David's referenced in the presentation, the data sharing element has been a bit of a hindrance, and it's been a tricky subject for those particular projects. I think on a case-by-case basis, we have picked up and got a solution for each of those PCM projects. We're just aware of there's a regional piece of work around a wider platform to share information. I guess whichever platform or however it's used, we welcome that support from everyone to do that, because I guess we need to make sure each organisation's got a data sharing agreement which enables us to share data for that purpose. But yes, it is a tricky subject, but that's good that we've got a plan to how we look at that area.
Yeah, I mean, it's probably worth mentioning that the ICS are developing a sort of data strategy, so I would expect that data sharing would be a sort of fundamental component of that.
Thank you. So I'll go to Alistair Blair and then come back to you, please.
I think the benefits point's really important. If you think for the most poor households, their fuel bill's gone up by on average £2,500, which equates across the county to, that'll be at least £42 million for the most poor. That's not across the county, and there's about 30 million in unclaimed benefits. So it just shows that the margins become really tight, and it's really important that we do kind of capitalise on those sort of things, because the maths is that this is a really big problem.
Thank you. Yes, please.
Thank you. Following on from Councillor Sanderson's well-made point about coming back every 3 months to give some evaluation of the key performance indicators. If this is going to be a rolling programme, and it could last for a long time, there's so many inequalities to deal with, might it be worthwhile giving indications as to which priorities you might turn your attention to as time elapses? Because you've got some clearly identified ones here, but there will be other priorities in each of these areas also worthy of attention. So might you give some indication as time progresses as to which priorities for each PCN you might be considering?
Can I just come in quickly? Have you seen the action plan at all? If not, then can I suggest that Inequalities Action Plan is emailed to all members? If it hasn't been, it's on our website, but I think it'd be really useful to do that. It's got key outcomes in there, hasn't it, Liz? So that's the first thing. The second thing I would say is, and I should have said this before, I don't underestimate and fully acknowledge all the work that is currently going on. There is masses of good work going on with masses of people, partners and our staff. But what this is to do is to say this is our political wish that we actually make this a priority, so we understand and support and will put money into trying to make it a little easier that every person in the county has an equal chance in life. And that's what this is about.
Thank you, Blair. Any other input, comments? Yes, please.
The action plan was actually part of the inequalities plan document that came to the board in September, so it's in there.
It's there. The action plan is there. Thank you very much, both of you. It was a very good presentation. Thank you. One more time. Let's move on to the 7th item, an update by Liz on living with COVID.
Thank you. So just to give you a sort of brief update on where we are with COVID, the latest ONS survey data, that's still really the best way of trying to establish what the trends are, but it is a few weeks out of date. So the latest data we had was published last week, and it referred to the week up to the 24th of September. And that suggested that the prevalence of infection in the community was increasing in England and Northern Ireland. It had gone up by about 66,000 from the previous week. So it's gone up from it's gone up to 1 in 50 from 1 in 65, and I don't think it's been below 1 in sort of 70, 1 in 75 for many, many months. The rates are highest in the Northeast. They're higher in primary school age children, so 2 to 11-year-olds and over 35s. Actually, the highest rates and the steepest rise are in people over the age of 70, which is a bit of a concern because obviously they are the most vulnerable groups in our society. I think probably that's being driven by a few variants that are floating around, but there's obviously something else going on because actually the variants, although they are contributing to some of the increase, the timing of the increase and the number of new cases compared to the prevalence of the different variants means that it's likely that actually behavioural factors are having an impact. So that's things like people spending more time indoors because of the summer and also waning immunity. So really I don't think we really know whether this is just a blip or whether this is going to be a concerted wave, and we'll just need to keep looking at the data. Certainly the symptom-related data suggests that, which is more recent, suggests that cases are continuing to increase. Obviously, we're not just concerned about COVID, we're also concerned about flu. And we often look carefully at what's happening in the Southern Hemisphere. And what has happened in Australia is that they have had a significant increase in cases of flu compared to previous years. I think they've had the highest number of laboratory-confirmed flu cases since 2017. And the other notable difference was that their flu season started really early, so it started in sort of May, June time, whereas normally they would have started to see an increase in sort of July. It doesn't necessarily follow that our flu season will look like what's gone on in the Southern Hemisphere, but obviously we just need to prepare for that. And clearly what we need to avoid is concurrent peaks of COVID and flu for sort of very obvious reasons. I think the advice is really simple. If you're eligible for a COVID vaccine or you're eligible for a flu vaccine, we would just encourage people to take up the offer. And, you know, if you haven't started your flu vaccination programme, it's not too late to either start it, pick it up where you left it off, or indeed to continue to take the autumn booster. It really is the best way of reducing the risk of illness from COVID, particularly if you're in one of those high-risk groups. And all of those behavioural interventions that we've been doing will also continue to be really important. So if you start to develop symptoms of any respiratory disease, then stay at home if you can, and that hands, face, space message is still really important. Richard's going to talk about the vaccination programme, but I think it would be useful to have some input from Alistair about what they're seeing in the Trust and the impact that it's having on the Trust, because it isn't just the direct impact in terms of admissions and patient flow, it's also the impact in terms of staff sickness. Alistair?
Thanks, Liz. Just a quick update on the figures. That there's currently 84 inpatients with COVID in the Trust at the moment. I have to say that most of those are people who have not been admitted because of COVID, but we are finding they are COVID positive and are also being admitted. So the COVID's not the main reason. There are 2 patients in ITU. So it does have an impact. It's worth saying that we've got 1% of our staff off simply because they're COVID positive, and if you're a healthcare worker, you can't have patient contact. So it creates quite a lot of logistic problems. So 1% doesn't sound a lot of staff, but that's enough to cancel operating lists and create quite a lot of pressure as a consequence. So our feeling is that, and we'll have to wait and see, is that we might just about be reaching the current peak, but we'll wait and see. I think Liz is right about the symptomatic presentations, and we haven't got the depth of statistics that we used to have. The ONS survey is really the only survey that we've got, and obviously that's more of a national picture than a local picture. So at the present time, pressured, but not particularly because of people being particularly ill with COVID. It's more of the unintended consequences of COVID, and also making sure we don't have outbreaks and things like that. So it does make sure that there's a lot of infection control measures that need to be done to stop it spreading internally.
Questions to Liz and Alistair? No. Okay. So you sorry?
Richard next.
Sorry?
Richard is doing vaccines.
Yeah.
So just moving on to the vaccination programme. Thank you for having us. My name is Richard Hay. I'm the Head of Planning and Operations at the Northeastern North Cumbria Integrated Care Board, working on behalf of Northumberland. And this is my colleague Claire Lynch, who's our Senior Primary Care Delivery Manager, who's going to talk a little bit later on about the flu programme. So what we want to do today is just give you a bit of an update on what's happening with COVID boosters and flu jabs. It's important to emphasise that they remain 2 separate programmes, albeit running alongside each other wherever possible. We're into now phase 5 of the COVID vaccination programme that started almost 2 years ago now. And as you know, flu is something we do annually in terms of vaccinating our most vulnerable residents. So both programmes kicked off in early September, prioritising our most vulnerable residents in the first instance. And what we want to take you through today is just some of the key points of similarity and difference to be aware of between the 2 programmes, particularly around eligibility, around access, which I know continues to be a real issue for some people, some of the nuances in delivery of the programmes, and then we'll talk a little bit about co-administration as well. So as I say, it's phase 5 of the national programme. The eligible patient cohorts for this particular phase are similar to what we saw with the booster programme last December when the Omicron variant first emerged. So our residents and staff in care homes for older adults as a top priority, all of our frontline health and social care workers, all adults over the age of 50, and everybody aged 5 to 49 who is in a clinical risk group or who is a household contact of somebody with immunosuppression, and also where carers aged between 16 and 49 have been included in the programme. There's an enhanced service specification, which is effectively a contractual mechanism to allow our primary care networks and community pharmacies to participate in the programme, alongside hospital hub sites for the vaccination of their own staff and some opportunistic vaccination of inpatients. So in terms of sites that the public can access, particularly from their COVID vaccination perspective, we've got 21 designated sites across Northumberland. So just to refresh people's memory, this is a slide we've shown the Health and Wellbeing Board before about the spread of sites in Northumberland. We've got 11 primary care network local vaccination services. So we've got the 7 PCNs that David was talking about before, but because some of those PCNs cover such large areas, particularly the north and the west, we have multiple PCN sites in those areas. There's 10 community pharmacies also participating in the programme. They're the red diamonds we've got there shown across the map. And as I mentioned, we've got the hospital hub site at Northumbria that's vaccinating their health and social care workers, and also the Mental Health Trust have got sites where they're vaccinating their staff as well. We have a roving vaccine unit that operates out of Cramlington and Seaton Valley PCN. which takes vaccines out and about to a number of different clinics and is also working across the whole of the Northeastern North Cumbria footprint. Our school-age immunisation service, particularly from a flu perspective, is going out and vaccinating in our schools. And we're working very closely across multiple agencies, particularly with our community nursing partners, to vaccinate our care home and housebound patients. What you'll also see in terms of the number of sites is that there are a number of hyper-local pop-up clinics. So within each PCN footprint, we have the ability to move vaccine around. So individual GP practices may well put clinics on for small numbers of patients in addition to those larger sites. We have some new vaccine products for this phase of the programme. They're bivalent vaccinations, so they're effectively updated versions of the previous mRNA COVID vaccines. The products that we're using is one from Pfizer and one from Moderna that have both been approved for use. And effectively, half of the dose in that bivalent vaccine is what people have had already and targeting the original wild type of the COVID virus. And then the other half is an updated version that targets the Omicron variant. So bivalent's the official word, but when I was trying to explain it to my 90-year-old grandmother, she thought, so like a cocktail, she said. So yeah, basically it's a cocktail of both strains to hopefully give people even fuller protection. The trial data shows there is a really strong immune response against both strains, so increased protection we can give to people. In terms of side effects, which I know people can be a little bit concerned about, they are similar to those that we've seen with the original vaccine products, which are typically very mild and self-resolving within a couple of days. There's also another new product just entering the programme at the moment, which is for those patients who can't have the mRNA vaccines for various reasons, normally down to very specific allergies. So that's a product developed by a company called Novavax, and that is becoming available, and patients are able to be referred to specialist hospital hubs to have that administered there. In terms of access and delivery models, I'm very conscious this is probably the most important part of the programme and one that's causing the greatest amount of confusion and consternation with our patients at the minute. There are two very specific access routes for appointments. There's something called the National Booking Service, which is what you get when you Google get a COVID jab or when you phone 119. All community pharmacy sites that are participating in the programme nationally are available on the National Booking Service, and there are some PCN sites that are accessible on there. In addition to that, there's then local booking, which is what we've traditionally done with flu jabs, where local PCNs and local practices will go out to their patients and encourage them to book locally, just with their own registered patient population. Now, what's happened with this phase of the programme is that nationally, millions upon millions of invitation letters and text messages have been sent out to eligible individuals, encouraging them to get their vaccine. As Liz says, it's a really important thing to get. At the minute, they've gone out to all over 65s and anyone that's on that at-risk list. And we know very shortly letters and texts will be going out to the healthy 50 to 64-year-olds as well, which is a big cohort. In the first instance, those letters and messages signpost patients to the National Booking Service. What the National Booking Service doesn't include is visibility of those appointments and those doses that are being delivered more locally, and that can often give a false impression of vaccine availability. In terms of some of the correspondence we've had into the ICB, I just want to do a little bit of myth busting to reassure people. We've seen some quite understandable things from residents and from councillors that there are no vaccines north of Ashington. That absolutely isn't the case. It's just very difficult to find National Booking Service appointments north of Ashington because we only have one community pharmacy site in the north locality operating in Berwick, but what we do have is a number of PCN sites in that space that are vaccinating locally and inviting their patients in. But what's confusing and what isn't necessarily clarified in that national correspondence is that you can wait to be contacted by your local PCN or GP practice and receive your vaccine more locally. Our PCNs are quite rightly working through, as they've been instructed, their priority cohorts in order, whereas the National Booking Service, again, is a little bit of a free-for-all. Once it's been decided that you're eligible, you can book an appointment. So what that does tend to create sometimes is a little bit of inequality inadvertently, that people who are more digitally enabled or are more tech savvy can get on and book their appointment. And that means that sometimes they're getting that before our more vulnerable residents. So it's really important we continue to support our PCNs to work through their cohorts in priority order. The other thing that's important to understand is that at the moment, a lot more letters and text messages have been sent than there are appointments currently available in the system. There are absolutely enough doses for everybody across the programme, but they're being delivered weekly to sites, and that supply is being spread across the duration of the programme. As has been the case since we very first started the COVID vaccine programme, supply of vaccine continues to be our great rate limiting factor. And as soon as we know that supplies are coming into sites, appointments are created, they're either put on the National Booking Service or new patients are invited in locally. So again, I think that can give the impression when we go on, when patients try to go on, that there's nothing locally, the only vaccines are available, maybe it's a 100-mile round trip away. Keep trying, I guess, is the key message there. Keep going back on, because new appointments are added all of the time. In terms of uptake and how we're getting on, I think it's important to note we're building on an excellent track record of uptake from the first phases of the COVID vaccine programme, and that in itself built on a fantastic track record of flu delivery, which Claire will talk about a little bit. We've seen some really strong initial uptake from Northumberland residents. We're ahead of the Northeastern North Cumbria average. Our care home residents absolutely continue to be our top priority. There are a number of factors that make that a little bit trickier at the moment, particularly the number of homes that we have in outbreak situations where there's COVID within the care home. But we're working with our providers and with our colleagues in health and social care to make sure that where there are homes in outbreak, we are absolutely prioritising the vaccination of those residents in those homes who aren't yet infected, so we can make sure we get them as much protection as possible. In terms of some stats, the early data is just starting to emerge, but already over 50%, 56% of our over 75s have been vaccinated, which, considering we've been going less than a month with the programme, is a really good start. Our frontline health and social care worker uptake is ahead of the Northeastern North Cumbria average as well, around 17%. The reason that's a little bit lower is because our provider organisations have tended to wait for their flu supplies to arrive and give kind of double bubble, give both doses to their staff at once. It's really important that we maintain public confidence and trust in the programme, and that we continue to promote uptake. As Liz has said, it is critically important. We have seen a significant level of dissatisfaction and frustration from patients with access and vaccines. That's why we wanted to come here today and do that myth busting. And we've been working with Claire and the council comms team to make sure we've got some really key messages that we can get out through all of our channels to make sure that the public understand that there will be a vaccine for them. They won't be missed. And as Alistair's mentioned, we've got cases and hospital admissions on the rise, so vaccination is absolutely our best way to protect everybody. I should also mention this isn't just boosters. We've got fantastic uptake of first and second doses in Northumberland. Certainly for first doses, we're in excess of 90% of all eligible individuals. But for that remaining 10%, it's not too late. There is still an evergreen offer available for their first and second dose and their booster dose. So that primary course of vaccination is still available to everybody. So in terms of just some key messages for COVID before we move on to the flu section, the single biggest message, which is why it's on this slide twice, is please be patient. You won't be missed. There will be a vaccine for all eligible patients. If you access the National Booking Service and appointments are inconvenient, patients should either try again at a later date when more vaccine appointments have been added, or wait to be contacted by their local PCN or GP practice. It's probably worth noting at this point we do have 2 or 3 GP practices in the county that aren't participating in the programme. They should have made their patients aware of the alternative routes to get vaccinated, and we're making sure that the community pharmacy sites in those areas, it tends to be around Ashington actually, we've made sure that the community pharmacies in those areas are receiving more than their fair share of vaccine to make sure that we've got enough doses in the areas. Co-administration is something that is absolutely promoted and encouraged, but not always possible because of the different supply chains and the different contractual mechanisms for delivering the flu and COVID programmes. So some people may absolutely be eligible for both, and if they're offered both at the same time, one in each arm, it is absolutely safe to have them both together. However, the advice is to please get each vaccination as soon as you can and as soon as it's offered, rather than waiting, as it might not always be possible to get them both together. So I'm going to hand over quickly to Claire, who's just going to cover the flu programme in a little bit more detail, because there's some additional cohorts that are eligible for that, and then we'll come back and I'll talk a little bit about how we're operating as a system.
Thank you. Thank you, everyone. I'm Claire Lynch, as Richard introduced before. I work in the primary care team at Northumberland. And I remember to click downwards to go forward, so that's a good start. So yeah, our the National Enhanced Service for Flu came out in August. We are around about 3 weeks into the delivery of that specification so far. And as Richard mentioned earlier, most of the cohorts are aligned with the COVID-19 booster programme, with the addition of pregnant women, children aged 2 to 3 years of age, all primary school children and secondary school children in school ages 7, 8 and 9. Really pleasing to report that all 36 of our practices in Northumberland are signed up to deliver both the adult spec and the children's specification. We also have a huge range of community pharmacies that are also on board with delivering the flu vaccination, as well as our school age immunisation service. I think the first thing to note is Northumberland has a really well established, excellent track record of delivering flu vaccinations. The flu vaccine supply started arriving around 3 weeks into the 3 weeks ago, and initial data shows us that performance is in line, if not slightly better, in some of our cohorts from last year, which is really pleasing. In fact, the over 65 cohort of patients will have over 47% have already been vaccinated, and actually we're leading the way across the Northeast, North Cumbria ICB, so that's fantastic. As Richard mentioned earlier, our care home residents are a priority in terms of flu vaccination as well, and our providers are working extremely hard to make sure that those patients receive the flu vaccination. We haven't had any issues, unlike COVID, in terms of the supply of flu, and no issues that have been reported in terms of availability of appointments. Clinics are well booked, they're well publicised, and our communities are working well to ensure that those slots are filled. As Richard mentioned as well, there are a number of our providers that are offering co-administration where supplies allow, but from a flu perspective, obviously, we need to make sure that those patients receive their flu vaccination, so please don't wait. It's really important. So in Northeast North Cumbria ICB, we recognise that there are 3 cohorts of patients that actually require a bit more targeted support. That is pregnant women and school aged 2 to 3 year olds to improve the flu uptake for this year. Alongside that, nationally there are a number of work streams that also recognise that these 3 cohorts of patients need some targeted support. So what we've done, we have 2 place-based commissioning services within the ICB who are actually trialling some vaccinations within nursery settings for aged 2 and 3 year olds. Very early days. I believe South Tyneside is one of the place-bases who are holding their first clinic next week. But that is a vaccination programme within local authority nursery settings, delivered by health visitor teams as well. So that's really exciting and really transformational, because collectively across the ICB patch last year, that cohort was quite low. So obviously trying to improve access for that vaccination is really pivotal. So it's exciting. The other thing that we have specific to Northumberland is we have a primary care commission services scheme, which looks to which we have commissioned our general practice team to deliver some incentivisations for via PCNs to improve care home and housebound vaccinations. So that's our practices working with our district nursing teams, sharing of patient data, sharing vaccine supply, just getting it moved across the system to ensure those priority patients are vaccinated. Alongside that, to ensure that our workforce is fit and healthy across the winter period, we've incentivised our general practice to encourage vaccination of clinical and non-clinical staff, because obviously they come down with either COVID or flu over the winter period. That's a staffing capacity issue, so it's really important for us to try and support that. We've also have an incentivisation to support the learning disability register of patients so they get their vaccine as well. Most recently, one of the more transformational work that's come out of the Northumberland Vaccine Collaborative, which I'm sure you're all aware of, as we are piloting, well, we're not piloting, sorry, we have introduced the offer of vaccine, COVID and pertussis vaccinations at both a 12 and 20 week scan. Early indications show that that is being accepted really well. I think the programme's been delivering for around about 2 weeks, and there's already been 60 plus vaccinations. So that's really good. So we're hoping, obviously, with those targeted transformational works that are being delivered across not only the ICB but at Northumberland Place level, that we'll see vaccination rates increase for Northumberland, and hopefully in a few months' time that we'll be able to see the fruits of that work as well. It's just worth mentioning around that maternity offer as well. It's a new offer, so to speak. So originally the vaccination's been offered in antenatal clinics, but maternity services are looking to put some outreach clinics in place as well around one spec. So it's obviously a growing programme and being well received. And Richard briefly touched on the comms and engagement campaign. The message is double your defences. You know, it's very safe for pregnant women. Make sure that if you're eligible for a vaccine, please take up the offer. The comms and engagement has been developed across the Northeast North Cumbria ICB, and it's been shared with all of our general practice and other providers. And there is a toolkit out there as well. So I think it's a really clear message this time around. So yeah, thank you.
Thank you, Claire. Just to cover off before we finish, how we're working as a system in Northumberland and trying to really integrate delivery of these vaccination programmes as much as we can. We've obviously got a huge network of providers and partners working together to maximise uptake across GPs, primary care networks, community pharmacies, hospitals, community services, the Mental Health Trust, our local authority partners and VCSE organisations. It touches on some of the stuff we were talking about earlier about inequalities. It's making sure that all of our partner organisations that have contact with our most vulnerable residents are aware of how people can access vaccination, and that's something we're trying to make really clear across the board. Claire briefly mentioned our Northumberland Vaccine Collaborative. That's a meeting that continues to come together regularly to troubleshoot any issues kind of live and make sure we can sort out any gremlins in the system and really enable effective partnership working across all of our organisations. There's also a wider Northeastern North Cumbria Vaccination Board, which is led by the newly formed ICB, that is working to ensure consistent delivery of the programmes across our local system and really share best practice. So some of our excellent track record of delivery we've got in Northumberland, kind of sharing the transformational work we've done and making sure that that's picked up by other areas. So we really are an exemplar in terms of delivery of this sort of thing. As Glenn was talking about earlier, and really, you know, what is a theme for all of us, reducing inequality is a key priority. We know with vaccinations that local providers and partners are best placed to work with their communities and neighbourhoods, and it's all about tailoring those key messages for our communities, using prominent voices in the community, accessing trusted voices to make sure we can get key messages out there. As I've said, we do have a strong uptake and a strong track record in terms of doing this, but we absolutely can't become complacent. There is some potential vaccine fatigue, I think, out there and amongst our public. You know, that, oh no, another one, really? Do I need it? Is it that important? I've had COVID a couple of times. It's absolutely really important that people keep getting jabbed, especially because this is a bivalent product with new protection in there. And this word twindemic is starting to emerge. There is that threat that if we get a peak of COVID and flu at the same time, that could potentially really overwhelm our healthcare systems. So, yeah, as important as ever to get vaccinated. Just to reiterate, and apologies for labouring the point a little bit, but I think it's really important that members of the board and residents and constituents are aware of this. Our residents at greatest risk do need extra protection this winter. The vaccinations will be critical to protecting lives. They've already saved hundreds of thousands of lives so far in our northeast region. If you can get them both at the same time, great, have them, it's safe, but don't wait for one to get the other, you know, get them as soon as you can. Just to reiterate again on the appointments for COVID-19 boosters, because I know it can be really frustrating, and I think we will see another wave of dissatisfaction and complaints potentially when the 50 to 64 national letters and national text messages go out shortly. People will find it in the short term incredibly difficult to find an appointment, so please encourage your constituents and residents to keep checking and see what is available, because new appointments are added all the time. Or the kind of the fallback option is to wait to be contacted by your local GP or primary care network. They will be supplied with enough doses and they will get to everybody in due course. And yeah, please be patient. Please be reassured you won't be missed. And there's just some more examples of the national and local comms that you'll start to see being rolled out a lot more now. They're images that we'll share across the council social media, as well as all of our local health and care social media. And happy to take any questions from people that they've got on the programmes.
Thank you very much. Thank you very much. Yeah. Are there any questions to? Yes, I'll go and then go there.
Yeah. Richard, I think when you're talking about patient dissatisfaction, one thing that would be beneficial when patients are using the national booking system is it not only shows the clinics which have appointments, but it actually shows the clinics which are full, because it would then mean they would know there are clinics available in their area, there are sites available in their area, but some of the sites are full. And then they would maybe wait and keep going back, rather than thinking, oh, well, I need to travel to Middlesbrough if that's the only site that's shown an appointment. I think that's a patient dissatisfaction, you know. I think as well, it's trying to get the patients to understand we're only getting a 1 week forward plan of vaccine supply. So the clinics do, fill up very, very quickly. And again, I think that is a communication issue to patients. And a final question for Claire. You talked about the enhanced flu service for Northumberland for health and social care staff. Is that because the pharmacy contract, the pharmacy enhanced service for health and social care staff, there's quite restrictions on. So if we're having people attend who want co-administration, unfortunately, for pharmacy contract, health and social care, we can only offer it to people who are either workers in residential homes or are actually out in the community, not other health and social care staff. So the service that you're talking about, is that just being offered through PCN sites? The enhanced service, I should say.
So the enhanced service specification I was referring to was the national one. In terms of the health and social care workers, there is an ICB offer to our staff, but I know that it's linked up with a number of limited sites within community pharmacy, which has been advertised, but I don't know if there's anything you would want to ask.
In terms of staff, they have broadened out the criteria actually recently to make sure that as many frontline staff as possible can be vaccinated either in a general practice or at a community pharmacy. So I think there's something about us as an integrated care system making sure we're communicating to all of our health and social care workers where they can get vaccinated. Obviously, in terms of co-administration at community pharmacies, that's a challenge because we've only got 9 community pharmacies delivering the COVID vaccine programme and lots of others delivering flu. Just on your first 2 points, we'll absolutely feed that suggestion into the team at the National Booking Service in terms of showing locations where clinics are that might be full to capacity currently. I think what we can do more locally is share that map that we had on there and let people know where all the sites are in Northumberland and reassure them which ones are local booking and which ones are national booking and what the various routes are. Your second point again, remind me.
It was just really that, we're only getting a week's advance notice of supply.
Absolutely.
I know at the beginning of September there was a 4-week forward plan, but that's now fallen to a weekly plan.
It has, absolutely, and that's been frustrating for us operationally. We are starting to move back towards that 4-week forward view. We've been able to inform sites of their allocations of vaccine for the week of the 24th of October currently. So we're moving towards that 4-week view again. We're about 2 weeks ahead at the minute, and appointments for those weeks will have fed their way into the systems. But yeah, it is supply absolutely continues to be our single biggest rate limiting factor.
Thank you. You have a question, sir.
Thank you. The 10% of the population who have not yet had their first COVID vaccination, it seems to crop up in every meeting, every report. And I know huge efforts have been made to contact this group of people and to try to convince them. But has there been any research into why the 10%. Why have they not taken it? Why do they not want to take it? Any research, any evidence which could be used to try to overcome this?
I would imagine there's the wealth of evidence out there in terms of data and behavioural insights that's being pulled together nationally and regionally. Certainly locally, we're trying to promote that evergreen offer as much as we can, and things like making every contact count. The maternity service that Claire described is actually a really good example of a service where we're getting people who don't traditionally access vaccination services, and by offering that vaccine when they're coming in for a scan, it's been a really positive way of digging into that 10%. So I'm sure it's something we'll come to in due course in Northumberland, David, in terms of how we look at the 10%. But in other areas, it's quite a bit more than 10%. We're really well off to be in that 90% bracket in the first instance.
Thank you, Alistair.
Yeah, I'm just conscious from a kind of patient point of view and mental health and everything. It's almost like left hand and right hand from the centre are not communicating. There was a national announcement about everybody over 50 should be getting the COVID jab. It doesn't help the health service, it doesn't help patients, and I think we need to feed back, because I think there will be mental health issues, people anxious that they can't get a vaccine that they think they're entitled to. That wastes time for them trying to pursue it. It wastes time for healthcare professionals being asked to provide something that they don't have. And I think the mental health strain on people, and I actually think people will give up and actually feel frustrated and not go for the vaccine if we'd done this in a timely manner. And I do think we need to feed this back, because we're setting ourselves up to fail, and we're setting ourselves up to miss patients' expectations, and neither of those we should be really counting and saying. And I know that's not a local issue, but we need to feed this back, because the central messages and the local messages are not remotely coordinated.
Yeah, it's a really good point, Alistair, and it's absolutely something through our system vaccination operations centre, which we run across the ICB. It's something we feed back on a regular basis. There is that disconnect between national and local comms. To be honest, I've probably said some stuff this morning that wasn't necessarily towing the NHS party line, but I think it's really important that we're honest with patients, and we do understand their frustration. We don't want people to give up because it's difficult to find an appointment. We want it to be really, really simple for them, and certainly locally we are acutely aware of that frustration, working really closely with local authority comms colleagues and PCNs and other healthcare providers to make sure we are busting those myths and getting that information out there.
Liz, yeah, please.
Thank you. Yes, it is hugely confusing. I've had many emails from elected members about the vaccination programme and, about patients' frustration in being unable to access a vaccine through the MBS, and I've been sending back the messages about, be patient. But but just for clarity, so for patients who are living in very rural areas, so out in Bellingham, out in the west of the county, obviously most of those are not going to be able to drive to many of the locations that are on MBS. But are the GP practices, are they going to be delivering the vaccination locally, or are people in Bellingham, for instance, still going to be expected to travel quite large distances?
So that example in the West that you bring up, the PCN in the West are in the vaccination programme. They've taken the decision to operate their designated site from Hexham Mart, as they did in the first phases of the programme, which has seen pretty good levels of uptake and people coming in. We are conscious, though, that there are some very rural pockets in the West that we need to address. The GP practices in the West as individual practices, and this is where the disconnect between how flu is contracted and how COVID is contracted in terms of the services. That's delivered at GP practice level. So we do have individual practices offering flu vaccinations. So we're working closely with the PCN to explore the potential for moving some of that vaccine out from the designated site at Hexham to practices and do some outreach, because we're conscious that those rural communities can be very isolated. So Bellingham and Haltwhistle are two areas that aren't currently covered, that we think we do need to do some outreach. There is a pharmacy service in Hayden Bridge and in Wylam that are helping to plug some gaps in the West. But yeah, there's always more we can do in terms of making vaccine delivery as local as we possibly can.
And are we still offering a transport option for those patients?
There is a transport option that we offer to all of the PCN sites. So we've commissioned Age UK to offer that transport service. That's something that GP practices and PCNs, when they contact their patients through that local booking option, should be offering to patients if they have trouble attending their appointment. We can use the Age UK service to take them in and back home to the appointment. Yeah.
Okay. Yeah, I think that's something that we need to communicate. I think the other point was just responding to David's question about research. There is a wealth of research around vaccine hesitancy, both generally and in particular around COVID. And a lot of the sort of comms strategies that we've developed have been based on specific behavioural insight. So we're actually tailoring our messages to so that they're in tune with what we're hearing from communities. But actually, in general, all of the work that we're doing in communities where the uptake is lower is based on the evidence of what works.
Okay, thank you very much.
No problem. You're welcome. Thank you for having us.
Very good update. So we move on to the next item, number 8, development session. I think it will be led by Graham. Briefly.
Thank you, Chair. This is really a reminder and an update. When we had our development session and we were organising ourselves around the themes of the health and wellbeing strategy, one of the outcomes was to align leads to the different themes. So my job today, I've got the table up in front of me, who we have now confirmed, and then it's actually to place an expectation on those groups of people around the themes to come back, having had a think about their theme, and develop an action plan against it, essentially. So it's to move us on from the development session. So the first theme I've got, best start in life. So we have the lead member is Councillor Wayne Daly, and then the executive director is Graham Writer and Audrey Kingham, and the public health support is John Lawler. Empowering communities is Councillor Caroline Ball, with the executive directors of Liz Morgan and Jill O'Neill, and the public health support of Karen McCabe. The wider determinants is Councillor Veronica Jones, the executive director Rob Murphin, public health support Liz Robinson, and the whole system approach is Chair Paul Ezilshaven, executive director Rachel Mitchison and Alistair Blair, and then the public health support is Jim Brown. So an action from this meeting will be to contact those leads and say, please could you now go back to the health and wellbeing strategy. And I think in our plan that came back, which I will need to double check with Jill, was actually some time frames on when those pieces would come back. And it's just to keep the momentum going and actually remember again that it all dovetails with the inequalities work. Yeah. So happy to take any comments on any of that, but it was really just an update. Yeah. The compact, yes. You'll also recall that part of the inequalities plan had a compact, which was to say that our partner members would take that compact away to their governing bodies or relevant committees, make sure it was socialised, discussed, to get that sign up that actually we were all serious about doing something with it. And we probably should have an update, I shouldn't say probably, we should have an update at the next Health and Wellbeing Board about where the organisations have got to with that compact, just to get confirmation of sign-off. So that would be another action point for everybody who feels that their organisation needs to discuss it at whatever board. So I would say every member in the meeting really should be taking that away and bringing it back with a reflection, because there'll be a challenge. There'll be people who are on that path of education around inequality and the ABCD approach. And therefore, we also have within the inequalities plan catch-up sessions to come with Cormac Russell around introducing the concept and doing the hearts and minds. So if people identify people within their organisations who think they would like to be part of a catch-up session, I think there's a very real offer of an invitation to those. Jill and I reflected yesterday on the one that we'd had in
in the council chambers yesterday that we very much focused that on elected members, but actually we could have had capacity to have had other people in the room on reflection. So I think what we're going to do is we're going to pick a core group of people who we wish to target with these sessions coming up, but we will also then send something round when we think we've got capacity to say, is there anybody else that you would like to send along? And then we can all keep learning together on that. Any thoughts or questions?
Yeah. Thank you.
Oh, we have one.
Yes,
Yeah,
we
go
have.
ahead.
It just again very much welcome that, and very much welcome being part of that wider ABC discussion with regards to what our contribution is.
And I think we specifically have kept in our mind that we need kind of a blue light session on some of that, with the wider group specifically focusing on your group and any others, and especially the police as well, I think, just to bring you on board.
Yeah, and thanks, Chair. I'm presenting at the November Health and Wellbeing Board, so I think to set some scenes with regards to the evolving offering of a fire and rescue service within this whole systems approach would be hopefully interesting for the panel members.
Excellent. We look forward to that. Thank you. Yeah.
Yes. Any other input for us? Thank you very much. In that case, we go to the forward plan. It's on the page 67. So the next meeting basically involves, at the moment, living with COVID update, safety and well-being visits. Is there anything else by Graham Binning? So we will, is there any suggestion that we add anything else that will be taken on board straight away? Liz?
Well, we've got the actions that we've just spoken about, haven't we? So,
Yeah, that's right, this compacting.
Yeah, so just thinking about how we're going to take forward the Health and Wellbeing Board.
Strategy
So
plan.
the Joint Health and Wellbeing Strategy
Yeah.
themes, and then an update on where we are with the compact.
Yeah. Right. Thank you. And I think there's an urgent business. That brings us to the urgent business, the penultimate item. There is going to be a ICS joint ask meeting on, it's not Monday 19th September, it is coming Monday 17th of October. So if you could move over these are the items they are going to discuss, and I'm going to attend. And if you have any questions to be raised there, I'm very happy to take those questions. Next steps for ICS, that's a very interesting topic. It's going on for a long time. And mental health collaborative, so if there is any of these items are closer to your heart, and if you have any questions, I can take it and then raise the question, and then I can give the feedback. Okay, thank you very much. Sorry, Liz?
Yeah, if I could raise one thing with respect to workforce.
Workforce, yeah.
Yeah, I think it's really important that the ICS doesn't think about the NHS workforce in isolation.
Yeah.
It's got to think about the social care workforce as well, because one doesn't function without the other. And sometimes there are unintended consequences from one bit of the system doing one thing, unintended consequences of the other. So we need to think of them as an integrated system, not simply thinking about the NHS workforce.
Any other? Yes, please.
Just a couple, I would second that, and even wider, the volunteer workforce as well, because without the whole system going forward, I think we'll be restricted in what we can achieve. The other one is around the mental health collaborative, and the mental health partnership that's coming into play, just how they will be the decision makers possibly going forward, and what that will mean at place. So previously we've worked very closely with CCGs around commissioning services in local areas, and I'm not sure how this will work within the ICB at how we allocate funds that are coming through across that whole system. So just something we're all a bit interested in, really.
Would you be able to drop me an email?
Yeah.
And then I can
And also to
Yeah.
Chris Angus, because we both are attending, so if you could CC Chris Angus as well, so that will be good. Yes. Yeah. Yeah. Any suggestion, please email to Liz, and then I will take it forward. Yes, please, Graham.
On the ICP structures, or the ICS structure, there was some discussion this morning. Nick Bailey is currently the interim post for Mark Adams, the area director of the ICB. And we discussed at the meeting we currently have a monthly meeting of chairs, council leaders across our footprint, which is the north of Tyne and Gateshead footprint. And we discussed that there has already been the first ICP meeting.
Okay.
Yeah. So Integrated Care Partnership, which is on the broadest footprint of the whole of our ICS region, which Paul has attended, I believe. Yeah. There is now a piece of work to go on around what our sub-ICP looks like. One of the aims of this is to very much make sure that local authorities are working in partnership with health, and it comes straight back to Liz's and Pam's point about workforce. So this morning at the meeting, Councillor Sanderson was there, and he said, what are we doing about the workforce for carers at home, for example? And there was a discussion then, and it was highlighted as one of the main things. And I think at a sub-ICP level, that would certainly be one of the places that we would have those discussions. For example, in Cumbria, where they have, North Cumbria, you might be aware of this, very, very similar problems. And one of their solutions has been to try and develop care workers within hospital settings with a view to then putting them back out into the community, in the idea that they'll attract other people who aren't currently working in the care sector to go and learn how to be a carer in the hospital and then put them back out in the community. What they found is, actually, because of possibly perceived better terms and conditions in the hospital sector, the carers who are working in the community are choosing to apply for the jobs in the hospital. So it's not solving the problem, which is a really good example of the system not working together, or thinking about what are the impacts we might have on each other here. And that's exactly the kinds of things that our sub-ICP, I think, will need to be thinking of. We think that there will be a quarterly sub-ICP meeting, which we think our chair will attend, but there'll be more of an executive input from local authorities as well at times, and the voluntary sector, so it will be a true partnership, I think. There may be more frequent private meetings to think about development issues as well. And Nicola Bailey is going away with those suggestions from this morning to come back with a plan which should come back to this board to say, this is what we think our sub-ICP membership will look like, this is who we think will chair it, this is the types of things that it will be considering. And hopefully you'll get that when you go to that meeting as well.
I hope so, yeah. Yes. I will definitely give an update after I attend it, yes.
Thank you.
Right. Thanks, Graham. That was very useful input. Okay, so the second business item is a bit of a sad thing, which used to be our regular attendee, and he was kind of ambushed in the conference in Birmingham, and by some ideological people, and asked lots of questions about health and well-being, and in front of camera and mic. And the trigger appears to be a very simple question he asked in this board meeting about cost of living, cost of wage, etc. So when he asked that question, to me it looked extremely sensible. But that question from the recording has been misinterpreted in the press, and then some ideologically driven people started blaming him as though he's a heartless person. And he has been subjected to enormous scrutiny unexpectedly in front of camera. So I really felt sorry, because the trigger event is a very simple question he asked in this meeting regarding cost of living. See, these this mob, both in keyboard warriors in the social media and also similar people, seem to think people of certain political persuasion cannot have heart, cannot have compassion, and it is their sole right to talk about well-being. And the second thing that bothers me is that this health and well-being is all about looking at data, understanding the statistics, etc. I've been teaching statistics in the university for a very long time, nearly 25 years. Sometimes you have to be careful when you analyze statistical data, right? One of the common things I say is that if your head is on a hot radiator, if your feet are on ice, melting ice, the statistics will say, on an average, you are comfortable. But we are not. Okay? We need to look deeply into what is it. So we need to look into other metrics like variance and standard deviation, etc., to come to the whole truth. So asking questions in these meetings is very essential in order to understand complex topics, as Glenn rightly pointed out, complex topics like inequality. We can't just go. Otherwise, my worry is that this will become our whole board meeting will become just a box-ticking exercise, which I don't want that to be. We all want to be involved in a discussion, asking questions. Of course, our experts have come up with fantastic data. In order to grasp the data, in order to understand the problem, and then formulate a policy, we need to ask discussions. But the fact that all our discussions are on record, on video, and everything, sometimes has unfortunately led to people being harassed because of not because of the genuine desire to understand, but because of their political persuasion. So sometimes, for example, if you look around us, they're all experts, there are no members. Absolutely no members, except for the leader as well as and the cabinet member. There are no elected members, even though their elected members are part and parcel of the body of this board. So it worries me sometimes whether that they can, whatever the questions they raise here can be picked upon in the social media, and then they can be subjected to harassment elsewhere, keeps them away from this meeting. So I need to discuss with the cabinet members and the leader to see whether how much of this meeting should be in public, right, or how much can be done in private. So that, because when the meeting is held in private, we can have a very good, open, free-flowing discussion to understand the facts, really. So this is the update I want to give you. So this is the discussion I want to raise with, from what happened to Councillor Jeff Watson. He's a regular attendee here, and I can see he's not here at the moment. So this is something I would like to raise with the council leader and the cabinet to see whether how much of what we discuss should be in public or how much can be in private. So this is something I would like to initiate. Yeah, just an update for you. Okay. Right, Liz? Now, the last item, date of next meeting will be on 10th November, 10 o'clock here, I think, County Hall, yes. Thank you all for coming, and thank you for all your questions and information and everything. Thank you.